So today we're going to talk about Chapter 21, Dermatologic Diseases. So just as we emphasized last semester in Foundations, do remember that the Braden Q scale is the number one assessment tool for skin integrity. You don't have to know what points go for what, but remember it does assess mobility, activity, sensory perceptions, as well as issues with tolerance of the skin and the supporting structure of the skin. So um, just remember Braden Q scale is number one. So, what can you do to help with skin integrity in the hospitalized child? Remember, we want to keep those pressure points protected, and you don't want to have things laying on the skin. You want to keep moisture wicking away from the skin. Those are big things you want to remember. So, changing diapers often, again, keeping moisture away from the skin. Stool, especially, remember that can break down skin much more easily than urine can. Keeping bedding dry. We want to make sure that they're not laying on anything moist. Keeping them well nourished, because if the skin in the body is well nourished, then the skin's going to get the nutrients that it needs to rebuild itself and kind of heal any wounds that are going on or protect from any potential wounds. Sorry if you hear something in the background. My dog's trying to play with me. You also want to keep the skin dry, which is basically what we've been talking about. However, remember if it's too dry, that it is okay to moisturize, because if it's too dry, you begin to get those cracks in the skin, which provides an opportunity for skin breakdown. Monitor for skin breakdown using that Braden Q scale. You also want to remember to turn your patients every 2 hours, especially those patients who are immobile and can't turn themselves. That way you're relieving those pressure points. Also, avoid scrubbing the skin when you're giving them a bath, because if you're scrubbing it, potentially you're going to maybe reopen something up or cause a new abrasion that could lead to potential skin breakdown if the pressure is just right on that area that was scrubbed too hard. So on this slide, I just wanted to remind you of the different type of skin lesions that you may see. Try to get my pointer here. So a cyst is going to be an elevated area on the skin. Typically they'll have a harder layer of skin around the cyst, but it will be fluid filled of some type of fluid. You have your fissure, which is going to be basically a crack in the dermis, epidermis. You can see how far they can go down into the skin. A macule is that flat, it's not elevated flat area, it's just a discoloration of the skin that's a different color. Typically it's round, but it doesn't have to be, especially if there's some kind of dermatological thing going on. If the border's acting a little funky, it could still be a macule as long as it's against the skin. You have a nodule, which is going to be an aggregation of tissue underneath the skin, so it's going to be hard for you when you're assessing the skin. And then you have your papule, which is just an elevation in the skin. There's actually no fluid in the papule itself. It's just an elevation in the skin. There's your polyp. You won't need to know that necessarily right here in this section. Pustule is going to be full of pus. So it's like a nodule, but it has pus inside of it. So it's fluid filled. And then vesicle is another fluid filled area, but you can see that it's much smaller than you would see in something like a cyst. So the first thing we're going to talk about is acquired disorders, and the biggest one here that's most common is going to be dermatitis. On this slide we have 3, and then atopic dermatitis is going to be on the next slide. So the first type of dermatitis is going to be diaper dermatitis, and this is when the skin around the diaper area becomes very irritated, and that can be from either an irritant that comes in contact with the skin, such as detergents, soaps, or some type of chemical, or it can also be caused by Candida albicans, which leads to candidiasis, and that is a yeast-like fungal infection. The difference is that with a regular diaper rash, it's really reddened. It's reddened, and you may see some little vesicles or shallow ulcerations there if it even gets to be that bad. But with candidiasis, it's actually a beefy red tender diaper rash. You may have papules, pustules. It is so red and painful. So you would know, you could be able to tell whether or not it was candidiasis infection or just from an irritant or from, sitting in urine or feces too long. I would probably say this is just a regular significant diaper rash. It looks not so hot, but it's not, to me, beefy red. If you look in your text, figure 21.3, that is a candidiasis rash, and it is so painful. Biggest thing with diaper rashes for nursing interventions wise is you want to make sure that you're removing soiled diapers as soon as possible, cleaning urine and feces off the area with a very mild cleanser. In fact, in the hospital, we typically just use warm water and a special cloth that's for sensitive skin. We don't use diaper wipes, baby wipes, that can irritate it. And you want to be very gentle when you're cleaning them because it hurts so bad. Also want to make sure you're exposing the affected area to air. Oxygen is going to heal that, making sure that it dries that moisture because the moist environment doesn't help the situation at all. So exposing the area to air about 4 times a day, 15 to 20 minutes at a time is helpful. If you can do longer, even better. But obviously they're going to have to go to the bathroom, so you want to keep them covered. But if the longer you can expose them, the better. You want to make sure that you're using a skin barrier too. So after you clean them, you put on a skin barrier, and you want that skin barrier to have some zinc oxide in it. At the hospital, you may see that depending on the diaper rash and the patient, they have different levels of treatment for each type, as well as different type of creams. So you may not have one with zinc oxide, but that's typically going to be the most common treatment that you see is that zinc oxide barrier. So you clean them off, you put that zinc oxide barrier over the diaper rash. That's going to wick away any moisture, any feces, urine, anything from that area and keep it protected. Now when you change the diaper the next time, you want to make sure you leave it on there. Don't wipe it off unless it's completely destroyed, because when you wipe it off and put it back on, that's just more irritating to the skin. So just leave it on if possible. When it comes to educating the parents and the caregivers on this, it's along the very same lines. Washing them with a very mild cleanser. Dove, Neutrogena, Cetaphil have a very good reputation for that. Avoiding vigorous scrubbing. Just make sure they're doing a very gentle scrubbing. Really don't use a washcloth. Use maybe like microfiber washcloth that you would typically wash a baby's skin with at home. That's very soft and gentle. Teaching them to leave the diaper area open to air as much as possible, as well as the barrier ointments. And do not use baby powder because baby powder can dry them out and cause it to be much worse. The next type of dermatitis is seborrheic or cradle cap, and that's what you see there in the middle. That is your very commonly looking cradle cap. It can also be found in the body folds. The most common one is going to be the cradle cap that you'll see. What causes it is kind of unknown, but they find that it's most common in infancy and puberty for some reason. It could be, I'm not really sure what it is, but it's also caused by some type of yeast organism. But you don't have to know that, but just know exactly what causes it. It's kind of unknown as far as like the etiology behind it, but there is a yeast organism as diagnostic wise that causes it. Nursing interventions or nursing care, gently rubbing the scalp or scrubbing the scalp to remove scales or crusted areas. Actually, petroleum, vegetable oil, or mineral oil can actually be really helpful for this area. You'll typically see mineral oil used in the hospital. Don't really see vegetable oil or petroleum. Mineral oil is usually our choice there. Use a fine tooth comb to remove any loosened crust from the hair, and shampoo daily with an anti-seborrheic shampoo. An alternative therapy to this that people could use is applying warm olive oil or baby oil, and then they wait about 15 minutes. You apply it to the scalp, wait about 15 minutes, and you shampoo the hair and brush gently. So the oil, kind of leave it on there for a few minutes, will kind of loosen up and soften the skin. Then they can shampoo it, and when they brush it gently, it kind of removes those extra crusties off. The next dermatitis we're going to talk about is contact dermatitis, and that is further broken down into irritant or allergic. Overall, though, contact dermatitis is an inflammatory reaction of the skin, and it's typically caused when the skin comes into contact with chemicals or other irritants such as feces, urine, soap, poison ivy, animals, metals, dyes, and different medications. With an irritant dermatitis, you're going to see arrhythmia, so redness, or erythema, excuse me, I always mispronounce that word, papules, vesicles, burning, maybe a little weeping, and that you'll see mainly with soaps and, like I said, irritating chemicals. So it's characterized by those, erythema, papules, vesicles, burning, and weeping. The allergic contact dermatitis is characterized by pruritus, so it's very, very itchy, and usually typically can be severe with erythema, papules, vesicles, and streaks or patches. And the typical common causes for allergic contact dermatitis, as we talked about, are going to be your poison oaks, ivies, and sumacs. Nickel that's found on buckles and jewelry can also be a problem when kids get older, but of course in the infants you won't see that as much. Really, the biggest thing we can do for the irritant dermatitis, contact dermatitis, is removing the irritant and then limit further exposure to that irritant, which makes sense. And then when it comes to an allergic one, that's with the poisonous plant exposure, you want to clean the exposed area as soon as possible with cold running water and then soap and a water shower. And again, this kind of goes along with education as well, because typically when we see them, it's going to be post exposure, so a lot of these things would be probably done at home. But you also want to talk about clothes, shoes should be cleansed in hot water with detergent. Calamine lotion really helps, or a natural oatmeal bath will help with all that itching. Use a topical steroid gel, corticosteroid gel, and then they may have to take an oral corticosteroid for a severe reaction if it's on the face, neck, or genitalia. Of course, also Benadryl is beneficial for nighttime. I guess you can see, you'll see throughout this that Benadryl is going to be perfect for helping itching at nighttime because it makes you sleepy. Hydroxyzine, which is going to be a Vistaril or Atarax, is perfect for daytime. So that's a typical treatment for an antihistamine to help control that itching. If they have any type of secondary infection with this, they're going to be on an antibiotic. And then possibly some type of antifungal ointment if there's a fungus that's causing this. As far as education, you want to make sure that the parents are aware if it's an irritant to remove that irritant and prevent further exposure from that. I'm kind of repeating what we just said. Also what we said with the allergic irritant when it comes to oak, ivy, or sumac, washing with soap and water has to be done within 15 minutes of exposure to remove those resin oils that come from the actual leaf itself. Applying a cool wet compress a couple times a day will help as well, soothe the area. Lotions and creams to help control itching. We already talked about the medications that they may receive to help that as well. And then if the rash gets extensive or is really bad, then you want to definitely seek medical assistance. And then as far as a complementary therapy, as we stated, for something we could do, you could do an oatmeal bath that will help decrease that itching. They really do, those colloidal. So another type of dermatitis I think you have heard of is atopic dermatitis, which is also known as eczema. So atopic dermatitis is actually a type of eczema. There are different types of eczema, and atopic dermatitis is one of them. So what atopic dermatitis is an inflammatory disorder that is triggered by an irritant, so such as a medication, a food, soap, maybe an animal contact on the skin itself, or a type of food allergy. It's characterized by scaly skin and really intense pruritus, so really intense itching. They're so itchy they can't stand it. They have to itch it. And of course, the more they scratch, the increased chance of infection. So we want to make sure that they aren't scratching those areas. Um, Typically, what you'll see in infants is called babies or infantile eczema. Infantile eczema is what it's called, and they'll tend to have it on their elbows, knees, face, and scalp, which you can see in the picture to the right. And then there is childhood eczema, which typically has an onset of 2 to 3 years, and then 90% of the children will have a manifestation by 5 years of age. And so you'll typically see that in the flexion areas on the wrist, neck, area behind the ears, and sometimes the hands. So where the wrist bends and in the back of the neck, you'll see eczema in those areas. In adolescence, you'll typically more see it on the hands and in the skin creases itself. But as far as nursing care and education, that kind of go hand in hand. You definitely want to keep that skin hydrated with tepid baths with or without mild soap, because you don't want to irritate that skin. They have very specific soaps and lotions now for eczema, people with eczema, because it is such a big deal to find something that doesn't irritate their skin. So they have a whole line of things, or things that have been approved by different societies and doctors to make sure that they're getting the right lotions and soaps without irritating the skin further. Um, Obviously, you want to make sure that they're avoiding the irritants themselves, avoiding excessive heat and perspiration, because we all know, even us without eczema can experience that, because when you're sweating, salt is coming out of that sweat, and that really is going to irritate that area even more. So make sure they're not in excessive heat. If they are perspiring and sweating and exercising, if they want to get rid of that clothing as soon as possible, that will definitely help take the risk of having increased irritation there. You want to make sure they're wearing loose cotton clothing. So that synthetic stuff can really irritate the skin as well. Moisturizing about 2 to 3 times a day. It could be more depending on the severity of the eczema. Using mild soaps, as we just discussed. Identifying triggers. So if you know there's types of food, types of animals, those types of things that are causing an exasperation of the eczema, you want to remove those and make sure you don't get around those anymore. Prevent scratching. So obviously, as kids, even as adults, it's hard for us to say, oh, I can't scratch that. But as a kid, they're going to want to scratch that. And it's hard for you just to say, hey, don't scratch that. So a lot of times you may see they will be getting medication to prevent the itching. So what you'll typically see is some type of oral antihistamine, hydroxyzine, so so hydroxyzine, also known as Vistaril or Atarax. Those are the two common names for that. Or Benadryl. You're going to see those to help control the itching or the urge to itch. Of course, those can all cause sedation or a sedative effect, so you want to make sure you're mindful of when they're giving those medications. You may also see loratadine, which is Claritin, or fexofenadine, which is Allegra, just to help with the allergy portion of that, as well as it also has an antipyretic or anti-itching effect as well. So you just administer those as prescribed, and then make sure that it's preferred for the Claritin and Allegra. They're preferred to be given during the day, and then the Vistaril, Atarax, and Benadryl are preferred to be given at night. So if you find that a parent is giving an Atarax during the day, child sleeping in school, okay, well, that's a nighttime medication. So make sure you're aware of that. Also, if there's a secondary infection, they may be on some sort of antibiotics. You may also see, as far as topical is concerned, a topical corticosteroid, which will help any type of flare-up and reduce inflammation. You also may see them use something called a topical immunomodulator, and what an immunomodulator does is that it stops the white blood cells in the skin, specifically the T cells, from producing inflammatory chemicals or those cytokines, which increases inflammation. So if it's put on the skin, it helps decrease the white blood cell or T cells from producing inflammatory chemicals or cytokines. So that's a non-steroid. Tac Tacrolimus, and then is one of the popular ones that you may see, but you can't use it for any child under 2 years of age. So, the last of the acquired disorders is going to be acne, and acne is the most common skin condition during adolescence. Those of you who are blessed of never having an acne issue, I'm very jealous of you. And so you'll see that a lot of times it can happen in early adolescence and go well into adulthood, but it is the most common skin condition during adolescence. Of course, it's a not non-life threatening issue, but the biggest threat it poses is on the self-image of adolescents. So you want to be very aware of the self-image issues that they may be having, especially if they have really severe acne. They can have a lot of anxiety, can go into depression, school issues. Just make sure you're aware of that when you're caring for those patients. And if you find when you're doing an assessment on them or a psychosocial assessment that if you find these things, you're making parents aware and kind of educating them on what could potentially happen and how to manage those issues. Interestingly enough, as far as risk factors go, acne actually has a genetic link. They have found a particular gene in a DNA sequence, and I can't remember off the top of my head what it is, but if it's repeated in the DNA sequence, then that person is more likely to have acne issues, which is pretty interesting. Of course, hormonal fluctuations in females can cause an acne flare-up, so typically during a menstrual cycle. The use of cosmetic products that contain ingredients such as petroleum or lanolin can increase acne outbreaks. Also, if you find an adolescent that is working, like say like the griddle or in a fast food restaurant where there's grease and smoke and those types of things, the cooking grease can actually get onto the skin and cause an increase in acne flare-ups as well. So they want to be mindful of that. And then there is possibly a dietary link with acne and eating a lot of high glycemic foods as well as dairy products, but there's nothing confirmed on that. I will say, however, a lot of people who cut dairy out of their diet, sorry, my dog, dairy out of their diet, or like for me, if I eat too much gluten, even though I'm not celiac, I found that a lot of gluten makes my skin worse. But when I cut it out and I monitor that, then there's not near as much of an issue. So you may just want to consider that if you find that people are continuing to have issues, specifically maybe when they eat certain things. So as far as nursing interventions or nursing care for a patient with acne, of course, you can discuss what acne is, how it occurs, if something new to them, the importance of adhering to the prescribed plan of care, just with anything else. You know, when you have antibiotics, some people don't want to take the full 7 days because they start to feel better. However, you have a risk of you rebounding and going back to the way you were if you don't fulfill the entire plan of care. So same goes with acne treatment, because they may see changes and their skin's feeling better and they're looking better, so they don't want to wash their face or put the same medicine on that they have been. So just make sure that they're following through with that. You want to teach the child, the adolescent themselves, that they don't need to touch their face or any of the affected areas that they may already have, and then they need to gently wash the face with like a mild cleanser such as Cetaphil is a very popular one, and not scrubbing the face and using those really abrasive cleaners, because that can really irritate the skin and actually make the acne worse depending on what's going on. You want to teach the child and the family about the medications that they are on, if they are prescribed medications. There's some pretty common ones that you'll see. So tretinoin that you may see, and then benzoyl peroxide is antibacterial agent. And then, as well as a topical and oral antibacterial agents, you may see those, so like tetracycline, doxycycline, erythromycin. Those are popular oral antibiotics that you'll see. And then topical antibiotics, clindamycin is a really popular one as well. The biggest thing you want to remember with all these medications, oral antibiotic, topical antibiotic, creams, antibacterial agents, whatever it may be for acne or just in general, you want to make sure that you're educating them on sun exposure and that they need to be wearing sunscreen at least SPF 15 or greater so they do not get sunburn, because they're more at risk for sunburn and a greater sunburn should they get out into the sun without any SPF. So educating them that they need to really avoid sun exposure, but if they need to go outside and do whatever they're doing, they really need to wear SPF or greater when they go outside. That is huge, huge, huge. Lastly, as far as medications are concerned, isotretinoin, also known as Accutane, a lot of you may have heard of this, is a popular one. However, it's widely talked about and a little controversial because it is so intense. It's used to treat really from moderate to very severe acne. However, isotretinoin is a teratogenic, so you have to make sure that before any female starts on this, if they're sexually active, they actually have to start taking oral contraceptives, typically two forms, but it can be one form, at least 1 month before and during treatment, and then at least 1 month following treatment whenever they're done with it, because you can only be on Accutane for a certain amount of time. I believe it's like 4 to 6 months, and then you have to stop it, because generally speaking it'll clear up everything. And then because it is so terrible for your body, really, I mean, you have to have blood drawn and everything to make sure that you're not pregnant as well, that you can't be on it for a long period of time. So make sure that if you have an adolescent that's going to start isotretinoin, that they're aware that they're going to have to be on oral contraceptives a month before, during, and a month after treatment, and making sure that they aren't pregnant already if they are sexually active. Another treatment of acne is oral contraceptive pills on their own, not just if they're taking Accutane. And so this does decrease the androgen production, so that will decrease acne development in the females specifically, because males are not going to take birth control. And it takes about 4 to 6 months to achieve relief from acne, so you may see a topical treatment be paired with that as well. So the biggest thing as far as education, we still kind of covered that in the nursing care, nursing intervention section, but just reinforcing the plan, encouraging a healthy diet, encouraging sleep and rest, because skin rejuvenates while you're resting and sleeping. And in addition to that, kind of goes to face washing. Make sure that they are washing their face at least twice a day, definitely before bedtime, because all those toxins and the environmental things that they run into during the day or exposed to, you need to wash all that off, wash makeup off, because the skin's going to renew and rejuvenate during the night, and having it free of any type of toxins is going to be best for the acne. Also, of course, avoiding tanning beds is best practice. And then again, sunscreen is great. Don't want to miss that sunscreen. Everybody should be wearing that when they're outside. And then obviously making sure they're following up with their dermatology appointments as needed. So now we're going to talk about bacterial infections, and the first one is impetigo. And impetigo is when you'll see it'll be like a reddish macule, so very flat, and then it becomes vesicular, so then it becomes fluid filled with some type of fluid, and then the vesicle will actually erupt, and that fluid will come out and it'll moisten the skin that's around it, and it will start to kind of erode a little bit. And then those secretions will actually dry and form crusty areas that you'll see right there on that child's face. That's exactly what impetigo looks like. And it's very contagious. It spreads by direct contact. It's very itchy. Because it is contagious, the child must be on antibiotics for at least 24 hours before they return to school or daycare. And that's really important for the parents to know, so be sure that you're educating them on that. As far as nursing interventions, definitely want to you yourself have good hand hygiene. You want to put this patient on contact isolation if they do come into the hospital with impetigo. Um, Management of impetigo, they'll have some type of topical or oral antibiotic. That's what you'll give them, and they want to educate them on those. You don't have to know specifically what kind, but they will be on some type of topical or oral antibiotic, if not both. Um, as far as education, definitely want to make reinforce the hand hygiene for everyone, especially the child, because more than likely they're going to be touching their face, touching whatever else. So make sure that they're washing their hands all the time. Prevent scratching, so you want to make sure that their nails are trimmed down. So if they do try to scratch, they're not as effective with some nails. And then, if appropriate, age appropriate, they may use some type of antipyretic, like a Benadryl or something like that. But it has to be age appropriate. You can't just give that to everybody. Also, make sure they're washing their clothes daily, because if the drainage gets on the clothes and somebody touches the clothes, again, that can affect somebody, so you want to wash those clothes daily. Cover lesions with loose cotton clothing if able as well. So you don't want anything that's going to irritate it any further. If for some reason the impetigo is on other areas of the body, you want to make sure that if you can, make sure that the clothes that they are wearing are cotton and they are loose and not too tight. So next we have MRSA. Typically this occurs in an area where there has been a small break in the skin. And what happens is that someone may be colonized with MRSA from maybe an old infection, but they don't have any signs of infection of MRSA. But they'll carry on the bacteria itself on their bodies, and then they pass it on to someone else, because it's through direct contact or indirect contact. Like, let's say people are sharing equipment, clothing, things like that. If it's not disinfected properly, then if somebody has a small break in the skin somewhere, all it takes is to have a little bit of MRSA contact, and bam, there it is. So that's why you may see patients, let's say if they come in and they had a previous MRSA diagnosis and their previous hospitalization, or even some type of medical records that they have, they will actually be continued to be tested, or they'll swab the skin to see if they have MRSA on their skin, if it's still present. And it's really important if they're in the hospital and they're having surgery or they have open wounds. That way you can go ahead and put them on precautions to protect yourself and other patients, as well as be aware of it and maybe provide prophylactic treatment in the event that they do have open wounds. That you don't want that MRSA getting into that wound. MRSA can present as a furuncle, like a boil, or a carbuncle, which is multiple boils, or some type of abscess. You can see the kind of that to the right. It often does get mistaken for a bug bite, and that's why a culture and sensitivity is so important to identify and treat the MRSA. So a culture will be where they swab the area and culture it to identify the bacteria that's growing on that wound. And then the sensitivity runs a test on that bacteria to see what antibiotics that bacteria is sensitive to and what they can use to treat it to get it to go away. The bad thing is if MRSA starts to spread to the tissue around the area, the soft tissue, it definitely can result in cellulitis, which we'll cover here in a second, so you can see that. As far as a nursing intervention, just be aware if you see any kind of drainage coming out of a wound and it hasn't been identified, go ahead and see if you can't get a culture ordered for that, to see if maybe MRSA is growing there. There's something else that you guys need to be aware of and treat, as well as covering any lesions that you already know have MRSA. That way they aren't sharing the love with anybody else at that time, and even protecting themselves. And you want to be able to teach the parents or the caregivers on how to cover that lesion at home. And then if they have antibiotics, you're going to of course administer antibiotics as ordered. You also want to make sure that you yourself are having really good hand hygiene. And then when you're changing the dressing, a lot of times you will use a sterile technique for changing that dressing. So make sure you're adhering to that and not breaking the sterile field. Because MRSA can complicate the healing of surgical wounds, as we kind of talked about a little bit ago, it's really important to make sure that everything is clean and you're really taking diligent care of your hands and making sure there's no extra risk of infection around. When it comes to education, make sure you're educating caregivers on the importance of completing all the antibiotics as ordered. You want to make sure they know how to change the dressing, that they need to keep the wound covered, but change the dressing as needed. Make sure everybody's washing their hands with soap for at least 30 seconds. Disinfecting the surfaces used by infected child. So anything that the child touches or uses, make sure it's disinfected. But the biggest thing about disinfection is that you want to make sure the disinfectants are actually approved and they say that they're effective against MRSA. Otherwise, you're not doing anything. You also want to educate them on the signs and symptoms of cellulitis, and if they feel that the child's lesion is getting worse and potentially could have cellulitis, and make sure that they know to seek medical care as soon as possible. As far as promoting safety or prevention, make sure that people are disinfecting, again, using the disinfectant that is effective against MRSA. People do not need to share towels or other personal equipment just in general. Doesn't matter if you have an infection or not. Just you shouldn't be sharing that because you don't know who's carrying MRSA on their bodies. I mean, you and I, because we've been in the hospital, we probably have some type of colonized MRSA in our nose. That's very common. So not picking noses or playing with inside the nose and touching something is also a good idea as well. Using a clothes dryer, don't air dry clothes, is best practice because the heat will kill the bacteria of MRSA, or prevent any type of spreading of MRSA. So don't air dry clothes. And then if you have any infection or open areas or boils or whatever you may have, make sure that people just keep them covered, because even if they don't have MRSA, we don't want MRSA to get in there. So now we have cellulitis, and this may develop where there is a break in the skin or possibly a recent trauma in that area. It's caused by group A streptococcus, which also is responsible for strep throat and impetigo. And if it's really bad, on rare occasions, it actually spread to the blood through the bloodstream and then to the muscles or the lungs, and then it can lead to necrotizing fasciitis. Of course, it's also caused by MRSA, which we just talked about, Staphylococcus aureus, and Haemophilus influenza. Local manifestations that you would see with cellulitis would be redness, it'd be very warm, it'd be swollen, and the area would be very tender. You may also see lymphangitis, which is also known as a red streak coming from the area. And you can see that very well in that picture on the bottom right. That's exactly what it looks like. It goes from the affected area down the lymph tract and just kind of keeps on going. So that's what's lymphangitis, and you'll see that. You may see that. Also, if it becomes worse and it becomes systemic, you would see symptoms like fevers, chills, and general malaise. And obviously that would not be a good sign. Typical testing that you would see for diagnostic purposes would be, again, a culture and sensitivity. So they would test the area of the trauma or the infection started to see what's causing this and see what needs to be treated. If they start having systemic symptoms or a fever, they'll actually do blood cultures to see if it's spread to the bloodstream. And then a CBC, you'll see, would be completed because they want to see, do a differential and see if there's any type of bacterial infection occurring. Nursing interventions, you're going to typically see them on some type of oral or IV antibiotics, depending on the severity of the case. You want to make sure they're resting and immobilizing the affected area. You're going to be assessing, huge things you're going to be assessing for are going to be perfusion. So You want to make sure that they have great capillary refill, their color is good, they're not too warm. You want to do it about every 2 to 4 hours. You also want to make sure that you're assessing for any type of local manifestations and monitor the site for any extra redness, swelling, drainage, those types of things. Assessing their temperature, heart and respiratory rate, and blood pressure, all their vital signs, because that could lead to being able to pick up on a systemic cellulitis infection if it's getting worse. Monitor their behavior and level of consciousness. You can put a wet, warm compress to the affected area that kind of helps with blood flow and healing in that area where the cellulitis is affecting the patient. And you definitely want to have these patients on contact isolation and make sure everybody's, practicing great hand hygiene. And then definitely don't want to you want to make sure, since they are in contact and they won't be able to really leave their room, that they do have some type of toys and things that they can play with to keep them occupied and kind of meet that psychosocial need. Education is kind of par for the course here. We kind of covered that. Again, completing all antibiotics as ordered when they go home. They can give their child Tylenol or Motrin for pain or fever, and they need to know how much they should be giving their child based on their weight. And you want to make sure that they know how to identify how much they need to give if the doctor doesn't tell them a specific amount. And then, of course, hand hygiene, and then seeking medical help if the child is getting worse. So now moving on to viral infections. This includes the papillomavirus or warts, herpes, simplex 1, of course simplex 2 is included, but simplex 1, remember, is cold sores and fever blisters, and then the genital herpes is actually herpes simplex 2. And then something that's more in your ATI, not in your book, is the molluscum contagiosum, and that's a pox virus. And I did this because you may very well see this. And that's just flesh-colored papules on the stalks in areas of skin, typically on the extremities, face, or trunk. And it typically will spontaneously resolve by 18 months, but if not, they'll usually use some type of cryotherapy or surgical removal of the areas that are there. Okay, as far as the papillomavirus goes, plantar warts, or warts that are on the feet, are caused by the HPV or human papillomavirus 1. And then common warts that you'll see elsewhere, typically on the hands, are caused by HPV 2. And the biggest thing about education here, that warts can be mildly contagious, but so just be aware of that, so not just rubbing them on everybody, or maybe keep them covered in school, especially for kids. And they definitely want to wash their hands after touching. You don't want them scratching or picking the warts. That can cause an infection or cause them to be worse. You don't want people sharing towels, just because, like I said, they are mildly contagious. And they can disappear without treatment, but if they don't, of course, common therapies are cryotherapy, or they make home little cryotherapy type things or medications you can put on them to remove the warts. So herpes simplex 1, this occurs typically near a mucocutaneous area, so anywhere where you have mucosa, so lips, nose in this case, or around the mouth, or inside the mouth. And there's very small, painful vesicles that you'll see, just like in this little picture here on the right. The incubation period of herpes simplex 1, which is, remember, incubation period is that's the period between when they're exposed to an infection and the appearance of the first signs and symptoms. So the incubation period can be anywhere from 2 days to 2 weeks. For the initial infection, if it's their very first infection, they're contagious for at least a week. But let's say they have a recurrent infection, they're not as contagious for as long. So they're contagious about 3 to 4 days. But nonetheless, regardless, they are contagious each time. Transmission is either from direct contact or contact with items that have been put in the mouth. So anything that's been put in the mouth goes into somebody else's mouth, and that causes an issue. If herpes simplex 1 becomes systemic and gets into the bloodstream, you'll see fever, irritability, and enlarged and very tender lymph nodes. Nursing interventions. You definitely want to have this child on contact isolation. Definitely want to make sure you're doing good hand hygiene and sanitizing all surfaces in the room. You also want to pay careful attention to hydration, because if their mouth is very sore and it's hard for them to swallow and it hurts so bad, you may find that cool, bland liquids are going to be best for them. So just make sure that you're assessing that and that you can actually visually see them comfortably drinking and eating with no issues. Um, Again, they may be unable to really tolerate oral liquids depending on the severity, so they may have to be put on TPN and lipids through their IV, that sort of thing. As far as education, you definitely want to educate parents so they can do a cool water compress to the lips. That'll kind of ease the pain a little bit, and if it's hot and itchy, that kind of helps relieve that. They want to make sure that they're using lip balm with sun-blocking agents to prevent any additional injury to the lip mouth area. There are also over-the-counter creams that have tetracaine cream in there, you want a 1%, and that can help as well. And then a mouthwash, actually they kind of call this, there's a magic mouthwash that you can get from the pharmacy that is prescription, but kind of an at-home magic mouthwash is 1-to-1 a teaspoon of Benadryl or half a teaspoon of baking powder. And they have to swish it and spit it. But they may also do like a Malox and a Benadryl mix, those types of things. But a teaspoon of Benadryl or half a teaspoon of baking powder in warm water. They swish it around and they have to spit. So make sure that they're swishing and spitting and not swallowing, because that can cause, Benadryl is going to make them sleepy. And if it's too much Benadryl, then that can be harmful. Sodium bicarb, which is also baking powder. Just make sure they are swishing and spitting. And that's the alternative therapy. So that little home magic mouthwash is the alternative therapy that I was mentioning. So now we move on to fungal infections, and this is the tinea. So tinea corposus is the ringworm of the body. Tinea capitis is a ringworm on the scalp. Tinea pedis is a fungal infection on the foot, so that would be athlete's foot. And then tinea curis is a fungal infection of the groin, also known as jock itch. As far as education for each of these, just in general, you're going to want them to apply an antifungal cream such as meconazole at least twice a day. If Make sure that they're not sharing hats, comb, brushes, ribbons, scarves, anything that's touching the skin or bedding, because that's how it can be transferred to one person to the other. A lot of times you'll see this in wrestling or sports where there's contact with people and things, that maybe somebody had a ringworm and then they just pass it on to that lovely person. Also, make sure that you're covering the lesions, they're not exposed. For tinea pedis or athlete's foot, make sure that you're airing the feet as much as possible so it's not moist down there, because they love that moisture. And then if they have to go anywhere and it's not too cold, sandals are always best. Make sure they're changing their socks daily and they're alternating shoes to kind of give everything time to air out. As far as tinea capitis, so ringworm on the scalp, you're going to shampoo the hair twice daily for 2 weeks with a special shampoo. And then systemic oral medications may also be required. So this is just a slide with just some visuals for you. So body ringworm looks exactly like this. Tinea capitis on the scalp, you'll see areas of the scalp that they're losing. It looks like they're losing their hair. It's very common. And then tinea pedis on the foot, athlete's foot, looks like this. And I saved you the visual image of jock itch, but if you would like to see it, you may Google it. So disorders related to contact with insects. The first one we'll talk about is lice. I skipped the previous slide with all the everything laid out is what we're going to talk about. But for lice, Typically, people have a hard time if they have a hard time figuring out if it's dandruff or if it's nits. Nits or lice eggs will attach to the base of the hair shaft so it won't move, whereas dandruff does move. Nits, they actually hatch in about 7 to 10 days, and once they do hatch, they become an adult louse, and then those little guys that start wiggling around and moving around the head, and so the lice will actually feed on the blood from the scalp, um, and they actually cannot live more than 48 hours away from the scalp, so they're always searching for the blood. So obviously you're going to see some very intense itching, and they are spread by direct contact between persons. So they don't fly or hop. People think they can fly around or hop. They can't. If you have like a bunch of coats hanging in the back of a schoolroom, touching each other, if a kid has a lice and the lice is, or the louse, depending on how many, I guess it would be lice because it wouldn't be just be one, are hanging out in the cap of somebody's coat, then they can go from coat to coat, and then children can get lice that way, as well as sharing hats, brushes, combs, towels, that type of thing. Because let's say you're combing your hair, you don't have any lice, active lice or louse, then the nits can get in the comb. Somebody brushes their hair with the nits attached to their hair shafts, and bam, you got the lice. So definitely no sharing. Nits are actually found really close to the hair base, so about a 1/4 inch from the base of the hair. And you just want to make sure that you're looking through the hair under a bright light so you can really see those nits. As far as education, alternative therapy, they'll definitely have some type of shampoo that's known as a pediculolide, pediculicide, sorry guys, for children, and it will typically have like permethrin 1%, that's known as Nix, or pyrethrin, Rid, Clear Lice, and Pronto are popular medications for that type. And they will leave the medication on for about 10 minutes and rinse it off, and then they repeat it in about 7 to 10 days. Definitely want to use a fine-tooth comb. They have to go through and remove the nits from wet hair. Make sure that the hair is wet because it's easier to remove the nits off the wet hair. The great thing is nowadays in Atlanta, they actually have a special hair salon for kids with lice or people with lice, and they can come in and remove the nits and everything for you, which is what I would do because this is a long and tedious process. Soak combs and brushes for about in hot water with one of the special shampoos for about 15 minutes. Wash clothing and bedding in hot, soapy water, and you want to dry on the hot cycle as hot as you can get it. If you cannot wash certain items, definitely dry clean them, get them dry cleaned. You want to make sure parents know to vacuum the floor, mattresses, soft and stuffed furniture, toys, personal items, and other objects that cannot be laundered. Make sure they're tied up in a plastic bag for more than 2 weeks. Because remember, the lice can't live for more than 48 hours without blood from the scalp. So the problem is if you have nits and some lice, then when those nits are born, you don't know how long it's going to take, and then so just leave everything in a plastic bag to suffocate those lice for 2 weeks. Do not spray the floor or other surfaces of the house and furniture with pesticides, as the chemicals can be toxic, even though, and technically sometimes it won't necessarily kill the lice. Alternative therapies, application of mayonnaise, petroleum jelly, or Vaseline has been recommended to suffocate the lice. Apparently parents are, they're told to put this on and then cover with a shower cap overnight and then shampoo the next morning. And even though people like to do this, it's not as effective as actually going through with a medicated shampoo and the normal regimen. So it's not going to hurt anything, but it's not really going to help anything either. Next is scabies, and this is actually a mite infestation. This is when the mites actually burrow under the skin, and they leave little lines or tracks of macules, vesicles, and pustules, and it looks exactly like this picture on your right here. It's very, very itchy, especially at night. In children that are about under the age of 2, you'll see them most likely affected on the head or their neck or on the palms and soles of their feet. But then in older children, you'll find it on the skin folds, lots of times in between the fingers and the toes. Other areas, of course, but the most common place I have seen them in older kids are fingers and toes. Actually, when I did school nursing, there was a girl and her sister, they were like second and fourth grade, and she came to me and she was itching so bad in between her fingers. And she had these little bitty bites in between. I was like, it looks like scabies. And so I notified her parents and they said, okay, whatever. A week later, she was still itching, and they went into the home and found like it was infested with all sorts of insects, and it was just a bad living situation. So you will really see it in between those fingers and toes. Education is really important here. Teach caregivers to wash clothing and bedding with hot water and dry on the hot cycle. Items that can't be laundered, you can actually leave them in a plastic bag for more than 5 days. You don't have to do 2 weeks for mites. They kill off pretty quickly. They're also going to have some permethrin cream, 5% actually, as opposed to the 1% you see in the shampoo. They're going to have 5% cream, permethrin cream, and they actually will put this cream all over their entire body from the neck down, and they put it on at bedtime, and they leave it on for at least 8 to 14 hours. And then the child can be bathed the next morning, and then you repeat that in 7 days. So they're like covered in this cream the entire night to kind of kill off those, not to kind of, but to kill off those mites. They can use over-the-counter creams to relieve itching at nighttime if it's age appropriate. They can give them Benadryl for sleeping so they can get some good sleep. And then since mites, scabies can be contagious, close contacts to the child also need to be treated. So if they're in the home, everybody in the home needs the cream. So very commonly at the urgent care, we will prescribe everybody who's in the house permethrin cream. Everybody has to put it on for preventative purposes. So next we have insect bites, localized insect bites. You'll see redness, swelling, localized pain. If you start seeing systemic reactions, you may see children throwing up. They may have a headache, they may have syncope, so they may faint, be dizzy, have highs, wheezing, or anaphylactic shock even. So hopefully, in the best situations, kids who know that they have allergic reactions to insect stings in school nursing had, bee stings and insect bites actually, or mosquito bites that had EpiPens. So in the ideal world, somebody who has anaphylactic shock will have an EpiPen. However, it's their first time, they don't know. Obviously, you want to make sure that they seek medical treatment as soon as possible. There can also be a delayed reaction to insect bites or stings, and that can occur as long as 1 week later, and that can include hives, fever, some joint pain, and those type of things. So be on the outlook of that, and it's important maybe educate your parents on that too if they're being treated or seen for those things, to kind of be on the lookout for any type of delayed reaction. Bees and wasps and everything with a stinger. What people want to do to manage this is, if they can, they want to remove the stinger with a little pair of tweezers. And you want to cleanse the area with soap and water. Apply a cool compress. I cannot talk today. Apply a cool compress to the area to keep that sting and whatever toxin may be there localized to that area, because heat is going to open up the blood vessels and everything else. Cool is going to restrict it, so we'll keep it localized. You can apply home products such as baking soda or lemon juice to ease the pain of the area, or even putting baking soda on a stinger you can't see. A lot of times it'll help get it out. Administer topical or oral antihistamines for any type of itching or inflammation there. If it's a severe case, of course, you hopefully have some type of epinephrine or EpiPen or corticosteroid to take. And then if you see those severe cases in the hospital, you'll see that they'll have some type of systemic steroid to decrease inflammation or release the cytokines in the body. That's very common. As far as ticks are concerned, depending on how long they've been there, if they've been there just for a few minutes or not very long, it's very easy to kind of remove those ticks. You want to make sure that you're pulling straight up with a steady, even pressure with the tweezers to remove the tick. don't twist because the head is typically burrowed in the skin. And if you twist, you're going to leave the head in the skin. So you want to pull straight out. Not advised at home, but if they go to the doctor's office, they'll probably remove the rest of the tick with some type of sterile procedure, um, with a needle or some kind to kind of make sure they get the whole any remaining part of the tick out. And you want to make sure that they cleanse the site with a good soap and disinfectant. And depending on how long it may have been there, they may go ahead and give a prophylactic antibiotic or treatment for the tick bite. These tick bites are also so very itchy. I just had one last semester myself, actually. I don't know where it came from. And they have topical creams you can take, or if it's really bad at night, maybe a Benadryl or something like that will help. But they are so, so itchy. And of course, depending on the situation, it could lead to Lyme disease, but we'll talk about that here in a little bit. A brown recluse, they can have pain up to from 2 to 8 hours after the bite, and then you may see like a star-shaped purple area in about 3 to 4 days. And then if it's really bad, a necrotic ulceration in 7 to 14 days. So you'll see wherever the bite is, it'll be a regular bite, and then you'll start to see necrotizing tissue. So a little black, kind of plateaued area in that where the bite occurred. And typically, if there's a systemic response, let's say it gets into the bloodstream, you will see fever, chills, weakness, nausea, and vomiting pretty much exactly 12 hours after the bite. So if it's longer than 12 hours and you haven't seen any of that, and you can educate parents on this too, then you can feel pretty certain that you're clear that it's not going to lead to a systemic reaction. For these bites, you can do a cold compress as well to kind of keep the toxin localized to that area. You may also see them on an antibiotic or corticosteroid. Depending on if it's really bad and they need pain, they may need an analgesic. If they're in the hospital, you can do maybe oral or IV. At home, it may be a topical analgesic. Just depends on what the doctor orders. And if the bite is really, really bad, the kid may need to get a skin graft because it could necrotize the area and they can lose some skin. Black widow bites, and if you guys don't see this in your book, refer to your ATI because I have a great layout of the bites and the management of these stings and things. It's a mild sting that they feel, and it'll have a very swollen and painful and erythematous, so reddened site. They typically will have dizziness, weakness, and abdominal pain. And if it's really bad, then they can be delirious, have paralysis, seizures, and even death, unfortunately. If they know it's a black widow spider, I would advise them to go to the hospital immediately just in case, but you want to make sure they're cleansing the bite with an antiseptic. Typically, you'll see apply a cool compress just to keep everything localized so it's not going systemically. They may actually get an anti-venom for the black widow spider, and then you may also see kids getting muscle relaxants because that will help with the severe pain. If they're having muscle cramping, abdominal pain, and back pain, that will help them to relax and help with any pain issues they may be having from that. Scorpions is going to be very intense pain. I've never been stung by one. I would never want to be. If you have, I can't even imagine what the pain would be with that. But you'll typically see a lot of redness at the site, burning, numbness. If it's really bad and it gets systemic, they may be very restless and have vomiting. Depending on the type of scorpion, you could have paralysis and even death. I honestly have never seen one of these ever in Peds. I'm just kind of making you aware of it. And the same treatment is pretty close. It's pretty much the same as for a black widow. But again, you don't have to know these things. I'm just making you aware, especially for these black widows, scorpions, those types of things. As far as nursing interventions for insect bites, just generally speaking, you're going to assess the skin at the local site and check for hives and other parts of the body. See if there's any evidence of associated infection from the bites and the stings. Look for any wheezing, any respiratory distress. That's going to be huge, especially if you think they're having an anaphylactic reaction. Another sign of anaphylactic shock or reaction would be hypotension and tachycardia. Excuse me. So if they're having anaphylactic reaction, you'll see some type of respiratory distress and definitely hypotension, so low blood pressure, and tachycardia. So heart rate goes up, blood pressure goes down. Also want to make sure you're assessing their level of consciousness. If they are having a reaction, they typically will give epinephrine 0.01 milligrams per kilogram sub-Q or IV, and they'll give that every 15 to 20 minutes as needed. And typically that's what an EpiPen does. If you ever have to use an EpiPen on a child, you call 911 immediately, because what can happen is that they can have a recurring episode. So let's say, okay, they feel better and they have their EpiPen, they're breathing better. Don't send them to class, don't send them back home. This is especially speaking if you're in a doctor's office, a school nurse situation, or out in the community. Definitely out in the community, because even if you're working in the hospital, you may very well come across a situation where somebody has an EpiPen, people freak out, they don't know what to do. So you use the EpiPen and you make sure you call 911 because they need emergency help. A lot of times as they get older, their reactions are different too. So if you're giving an EpiPen and 15 minutes later they can have another reaction. So just be sure to call 911 as soon as you use the EpiPen and tell the parents to do the same. Don't just think everything's fine and dandy just because you've given that EpiPen. In the hospital, you may also be giving 100% oxygen. Obviously, you want to make sure you get an IV, and then treatments as necessary. Education purposes and alternative therapies, we've kind of touched on this, but just to review, teaching them how to use an EpiPen, when to use an EpiPen, and what to do after using an EpiPen if the child requires one. Giving an oral antihistamine if the child is able to swallow. That will kind of help slow things down inflammation-wise, as well as any type of reaction they may have. Benadryl's a huge one that you'll see. So if they get bitten and maybe they don't have a severe reaction, if they're able to take a Benadryl, go ahead and tell them to give a Benadryl. And then they need to follow up with medical care immediately for any systemic reactions that they might be concerned about. And that's for emergency wise. Things at home that they can do: washing the wound, cleaning it, applying ice, and elevating the extremity to decrease blood flow to that area. So you want to put on ice, a cool compress, elevate the extremity that's affected. Tell them not to squeeze any stingers because it can crush the stinger inside. You want to make sure you pull it out with tweezers or a special scraper, but I prefer tweezers personally. Again, you can give Benadryl, and make sure, ideally, if you're with somebody who is having issues with bites and things, go ahead and tell them what the appropriate dose is for the age and weight. Weight based is best, but age wouldn't hurt. Typically, you'll see that age dosing is going to be less than weight dosing, because I have lots of parents all the time say, oh my gosh, I don't give them enough. And that's because they look on the bottle and see age-based dosing, whereas their child may weigh more than what the typical age range is, and they can actually have a little more. So make sure they're educated on how much to give. Obviously carrying an EpiPen, giving it to the school nurse. If they typically they'll have one with them and one with a school nurse, though a lot of schools won't let them carry it anymore, which I don't really agree on. If I was a mom, I'd just have my child hide it in their bag anyway, but that's just me. And then if it's really bad, make sure that they have a medical alert bracelet. And then wounds that are draining or have a necrotic center must be assessed and not always assumed to be a spider bite. And many spider bites diagnosed by parents or caregivers turned out to be staphylococcal infections and spider bites. So just make sure that they just don't assume it's one thing or the other, that if they do see some black tarring or charring going on in this bite, that they get medical treatment immediately. And then if they do have a spider bite, tetanus immunizations, make sure that they're up to date. And then we kind of already talked about this, but a baking soda paste, so baking soda mixed with cold water, can soothe a bite sting. So Lyme disease, it is caused by a bite of a deer tick that transmits an infective spirochete. And that is here. This little Spiro guy is over here to the left. That's what he looks like. And signs and symptoms appear anywhere from 3 to 32 days, but it can actually um, appear in even a year after you get bitten. Um, Stage 1 is technically like 3 to 30 days following the bite. Stage 2 is 3 to 10 weeks following the bite. Stage 3 is 2 to 12 months following the bite. So early on, 3 to 30 days, you may start to see redness at the site, maybe some chills, fever, headache, muscle weakness, and you see this bullseye rash at the side of the bite, and that's stage 1, and that's what's in that picture right there on the bottom. Stage 2, which is 3 to 10 weeks following the bite, that's when you start to see some systemic involvement, as well as some paralysis or weakness in areas of the body, and large joints are going to be starting to get swelling. So your knees, the larger joints, you start to see more swelling in. And then 2 to 12 months following the bite, more advanced systemic involvement, and even cardiac complications, those types of things. But generally speaking, the beginning of Lyme disease, you'll see a large circular rash with a central clearing. Bullseye rash is very common with Lyme disease, as well as a tick bite, but you'd be more concerned about Lyme disease if you actually see this bullseye rash. So you may see these people on an antibiotic. It could be a 2 to 3 week course, depending on what's going on, especially if the disease has been confirmed. And then they're just going to have to be, a lot of times these people will go see a specialist who know Lyme disease very well, and they'll be treated and kind of seen by them on their own. As far as education and prevention of Lyme disease, make sure that people are avoiding tall grasses and bushes where ticks like to live. Wear light colored clothing with long sleeves as well as long pants. That way, if a tick gets on your clothes, you can see it better and you're covering your arms and your legs. Wearing closed-toed shoes and tucking your pants legs into socks will help them from kind of shimmying up your pants. Using DEET spray on your skin, even though there's kind of some conflicting information on DEET spray as far as whether it's good for you, bad for you. There's that high percentage DEET spray that really keeps the ticks and the mosquitoes away. You don't want to use it all the time, but you definitely want to use it if you're going to be getting down and dirty in the brush. That way you can protect yourself from ticks. And I would just check out that little promoting safety box in your text on 487 that kind of goes into the safety uses of DEET because it can cause some issues. Home care, this kind of goes along with the ticks. We already talked about the tick bites. First aid removal, we talked about that, how to remove ticks. Do not squeeze them. You want to use tweezer to directly move them, don't twist. And then use gloves or tissues if they're available, and everybody needs to wash their hands. And then if there's part of the tick that remains in the skin, you can go to the doctor and have it done, or you can soak the skin to soften it and then remove any tick parts the way a splinter may be removed, sterilizing a needle or using tweezers. Also, citronella or lavender oils may be used to prevent tick and other insects bites in children over 2 years of age. There's no medical evidence that says it actually helps, but some people like it. Again, it's not going to hurt anything, but it's not going to maybe help anything either. So next, really quickly, we're just going to talk about disorders related to injuries, and that will include lacerations, bites, both animal and human, sunburns, and then burns. When it comes to sunburns, education is key. If I were you, I'd be very aware of this slide and the information on it because this is a big issue, and you want to make sure you're educating them appropriately. Infants that are less than 6 months of age should not be in direct sunlight, and if they are going to be, make sure they're under some cover. They have a hat, they are well covered, because you can't put sunscreen on kids less than 6 months. You can start putting sunscreen on kids 6 months or older. So you really want to be aware and diligent with infants less than 6 months as well as older, but definitely less than 6 months since you can't put sunscreen on them. Greater than 6 months and children should not be in direct sunlight between the main sunlight hours, which are 10 a.m. to 4 p.m. Make sure that they're wearing protective clothing. It's always good too that if they can wear t-shirts or those little surfer shirts out into the pools and things like that to protect their body, that's great. They should be applying a sunscreen that has a SPF 30 or greater. It should be applied 30 minutes prior to sun exposure and then reapply every hour. And again, they can start wearing sunscreen when they're 6 months old, but make sure it's baby sunscreen. And you're kind of looking at the ingredients in there. You also want to be sure that they're using water resistant sunscreen since they are going to be on the pool and playing around a lot and sweating, those types of things. That's going to be more beneficial. So the last thing we're really going to talk about here is burns. As far as assessment of burns, you want to look for risk factors. So risk factors for burns are going to be abuse, neglect, or lack of supervision. Those are all risk factors to a child getting burned. As well as developmental growth of a child. So are they mobile? Are they crawling? Are they walking? Are they risk takers? So when they get to adolescence age and they become more of a risk taker, those type of things. Look at the developmental stage and are they at risk for burns? Because even if they aren't burned, it's our job as a nurse, of course, to assess environmental issues and to educate caregivers. And if the children are old enough, educate them on what to potentially look for and what are hazards. As far as subjective assessment, you're going to see, find out what type of burn it was. Is it electrical burn? Is it a thermal burn? Those type of things. Is it, how long was the duration of contact? Sorry, it's covering, that picture's covering it up. The duration of contact of the burn. Parents can tell you how long they were touching it maybe, or how quickly it happened, those type of things. As far as objective assessment, you're going to see the stage of the burn. So first degree is going to be a superficial burn. Second degree is going to be a superficial, partial thickness, and deep partial thickness burn. A third degree is going to be a full thickness burn. And then a fourth degree is going to be a deep full thickness burn. And to review this, the stages of burn, your page 207, your ATI, chart 32.1 does a great explanation of what each part of the epidermis, dermis, that type of thing is affected with each stage. So I would look over that and so you know what superficial, what does deep partial thickness mean, those type of things. When it comes to figuring out the extent of injury for burns, they use something called the rule of nines, and it's different in babies. Typically a baby will have, instead of 18% for the head, it'll be 21%, but I'm not going to ask you specifically about infants. I would just, percentages of a child, they use this right here up until they're about 10 years old, and then when they hit 10 years old is when they go to the adult. So anybody under 10, from 1 to 10 years old is going to be using these percentages. And so TBSA is going to be your total body surface area. And then that just means the extent of injury to the body surface, which again, the rule of nines is going to be expressed in percentages. Infant skin, of course, is thinner, so their extent of injury is going to be likely deeper. So let's say this child was burned on their trunk, their chest, and their full trunk on the front. So that's 18%. Well, a baby could have the same injury, but it's most likely going to be a different degree because it's thinner. So it's going to be deeper more than likely. So depending on the grading or the classification of the burns, is going to be how they're treated. So if it's a minor burn, which is less than 10% of the total body surface area, they're going to be treated typically in an outpatient setting. If it's a moderate burn, which is 10 to 20% of TBSA, they're going to be treated in a hospital with more than likely like an ICU setting where they understand how to care for burns. But if it's a major burn, which is greater than 20% of your TBSA, or if it involves the face or the eyes or the ears or the hands or the feet and genitalia. Doesn't necessarily have to be all together. That's considered a major burn because it's so close to the airways and critical areas of the body. Then they're going to be going to a burn, like in an authorized, credentialed burn center. I think in your book it may say greater than 30% for a major burn, but go based off this, it's going to be involving greater than 20% of TBSA. So I would be aware of what the percentages are for a child for the rule of nines, okay? So you have your face, not your face, your whole head is 18%. So technically the front of the face is 9, front of the head is 9, the back of the head is 9. 18% for your whole chest and trunk area on the front, 18% for the whole back area and your trunk on the back. So 18% front, 18% back. 9% on the arms for each, 1% for genitalia, 13.5% for legs. So if you think about this, the buttocks is included on this back here. Everything else can be cut in half. So if it was half the chest, it would be 9, lower 9. I would never ask you a question like to trip you up. But know that for the arms, the front's 4.5, back's 4.5. Front's 4.5, back's 4.5. The head, front of the head's 9, back of the head's 9. The only thing that's not really cut in half is this area, because if it was the entire front is 18, the entire back is 18. Genitalia itself is 1%, but then you cut 13.5%, and that's whatever half of that is would be the front, half of that would be on the back. But if I were to ask you a question on this, it would be full numbers. So hopefully it didn't confuse you. Just know the whole numbers. The head's 18%, the front of the trunk and the chest 18%, back 18%, whole arms 9%, whole other arms 9%, genitalia is 1%, whole legs 13.5, whole legs 13.5, and it all adds up to 100%. So just talking about, excuse me, nursing care and nursing actions for children with burns. For minor burns, you just cover the burn with a clean cloth, provide warmth because the skin is damaged, and you know that skin is what keeps you warm. So when it's damaged, it's not ever able to regulate temperature as well, so they tend to be very cold. And this is like a minor to moderate burn. Actually goes all the way across the board. The moderate to major burns are going to be colder because it's going to be more of a body surface area issue. But minor burns, I mean, if it's a 9% burn, that's a pretty decent burn, so they still can get cold. If you see blisters, don't pop blisters. That can be a nice little harbor for infection there. There'll be a use antimicrobial ointments. So bacitracin is typical for topical burns and to prevent infections, so you'll see that. You definitely want to check immunizations, make sure they're all up to date. Specifically, the tetanus is a big one. And if they don't have that, then they're going to need it. Educate the family to avoid greasy lotions or butter. For some reason, that's an old wives' tale as to putting that on there, but that can actually lead to more infection and cause problems. And then educate the family to watch for infection. When it comes to major burns, maintain airway and ventilation is going to be your number one. Okay, so if you get a question, you want to maintain that airway always. Airway obstruction can occur immediately after a burn or over 24 to 48 hours after injury. So you really want to monitor, and if any of you have seen Grey's Anatomy or any medical show where there's slit on their nose, like around their nose or in their mouth, or if you see singed hair on their face or they have a burn on the face or neck, definitely monitor those people, especially those with a soot, because they may not have, you could potentially miss it, or it could be back in the back of their throat, and then 24 hours later they can't breathe all of a sudden. So if you're able to get that under wraps before it even occurs, that would be best. So you want to watch for coughing, wheezing, or dyspnea. Okay, those are going to be your 3 big signs that you're about to have a big issue. You're going to give them 100% oxygen, especially if they're in a confined space. You want to watch out for carbon monoxide poisoning. And so a big sign of carbon monoxide poisoning, along with the neurological they're disoriented, those type of things. Look for mucosal redness or erythema and swelling, followed by sloughing of the mucosa. That's a big sign of carbon monoxide poisoning. You're going to monitor their vital signs. You're going to place IVs, big, large bore IVs, as big as you can, to make sure that they're getting this fluid replacement that they need. And you're going to monitor for septic shock. And when you're monitoring for septic shock, watch for an increased capillary refills. They're going to start spiking a fever. Their extremities are going to be mottled. They're going to be tachycardic. They're going to have tachypnea, and they're going to have decreased urine output because their body is dehydrated. I mean, they're burned, so their body is not able to retain fluid as it would with a normal skin, because your skin holds in all your fluids. When it's burned, everything can seep out. So you may see a lot of seepage on the burns themselves. So septic shock, increased capillary refill, spiking of fever, mottled extremities, tachycardia, tachypnea, and decreased urine output. You're going to manage their pain. And remember, this is important. You don't want to give them any IM or sub-Q injections, because more than likely they're going to be burned in those areas, and you definitely don't want to be putting a needle through that into the skin. And their skin, a lot of times too, into their muscle or into their sub-Q tissue, and they could have their burn all the way to the muscle. So it's not going to be effective or painful. I mean, it's not going to be feeling good either. So manage pain with their IVs that they have placed, or a PO medication if they have a good airway and they're able to swallow. But more than likely it's going to be an IV pain medication. No IM or sub-Q. Do what you can to prevent infection, so make sure good hand washing, monitor for signs of infection. Nutrition, as we kind of talked about earlier on, nutrition is important for healing. So you want to make sure that they're getting the right nutrients. So if they're unable to swallow, make sure they have an NG tube placed if it's appropriate. If their airway, if nothing has been compromised in that sense, even if they have a breathing tube, of course they can have an NG tube. So make sure that's placed for some formula feeds, or they may give some TPN or lipids. Generally speaking, it would depend on how severe the burn is, because they don't want to put TPN, and lipids can have a effect on your liver and your kidneys and things like that. So they don't want to put extra stress on those. So that might be a last resort. So typically, nutritional wise, you may see NG tube feedings. You're also going to want to increase the caloric intake to meet the demands, because the body is healing and a lot of the body's been burned. You're going to have increased metabolic demands, and so you're going to make sure you give them enough calories for that. Also going to want to make sure increasing their protein intake to prevent tissue breakdown and promote healing. Protein is huge for that. You may also see them getting vitamin A and C to facilitate cell growth, as well as zinc for some wound healing too, as far as nutrition is concerned. Mobility wise, you want to make sure that you splint extremities and maintain correct body alignment. They can, depending on how much is burned, they can develop contractures in their arms. So say their arms are burned, they can be contracted, or their legs, they can get a foot drop. So make sure you're splinting things as you're able to. Do active and passive range of motion with them. And then as soon as they're able to ambulate, make sure that the child is up ambulating and walking around and those types of things. Definitely want to make sure you're looking at that skin integrity, because they're going to be at higher risk for pressure sores, especially if areas that are burned. So make sure that they're supported and they're being turned and those types of things. Psychological support's going to be really big for these kids. Give them developmentally appropriate support depending on their age. Assist them with coping as best can. So child life may be good for these kids. Definitely use our family-centered approach that we want to use for everybody. And then if there's referrals to like psych or something like that, make sure that you're notifying the MD of those and getting them. And the last thing we're going to talk about as far as more nursing care, wound care. When it comes to debriding wounds or changing dressings, these are so painful. It's going to be more painful for those more superficial burns because the deeper the burn, the more the nerves are affected and they can't feel anything. So definitely pre-medicate these patients. Analgesics, a little opioid, not too much, just enough to take the pain off. Hydroxyzine, so Vistaril or Atarax, will be beneficial in this situation. For any type of itching, because they can have a lot of itching with the healing process, as well as Benadryl for nighttime, diphenhydramine for nighttime is going to be big. But definitely pre-medicate for pain. It'd be so nice for you to do this. You're going to remove the wound if you're able to. Actually, this is something you can do. It's not a big issue, and it's just like burns that you're able to change the dressing on. You're going to remove the dressing, assess the site, of course, see if there's any signs of infection, if it's oozing, if it looks funky, something's not right, assess the wound, and then cleanse it as prescribed, and then you're going to redress it. Skin coverings, which are also going to be grafts. The biggest thing you can do as a nurse is you want to make sure that the site that has the graft is immobilized. Too much movement can affect the graft and can hurt it. So make sure it's immobilized. Elevate that extremity that has gotten the skin graft. This can be painful too, so just make sure you're giving analgesics as needed. And then you're going to monitor for infection before the skin graft, because you obviously don't want to put a skin graft on an infected site, because then you're going to lose the skin graft, no doubt. So make sure before the skin graft is being placed, you're monitoring for infection and notifying the doctors of that. And after application, make sure you're monitoring for infection. And that is really it. I realize at the end of this now that I totally forgot to insert my slides for lacerations and animal and human bites. So just look over that section in your text, and we're going to review to see if you have any questions next week anyway. And before the test, of course, I'll make sure that you're kind of aware of what might be important for that area.